introduce yourself. We're recording now.
Okay.
Go ahead.
It's a pleasure to be here today. I'm Almaguel from University. I am very excited about changing the outcomes of prostate cancer. I think we are in a time that is so unique that we're going to have many and many opportunities of being part of this change. I would like to, is there a way for me to control the PowerPoint, or?
If you give me a second, I think I'm in,
Okay, no worries, whenever you're ready.
well, okay.
So what I'm trying to say is that in the past, we had the chance of treating patients with our heart, right? Whatever we felt that was the right thing to do, we will do our best as physicians, right? We do this oath that basically we're going to help patients, right? And we will do our best to find out what the patient has in order to give them the best treatment that we know, that we knew of, that we could do, right? Now we are in a position where, go here, we are taking away not only, let me see, no, this is going all the way up. All right. So we are in a position now where we are eliminating chance from patient care, which I think is amazing, right? If we can tell you what is the right therapy for you at the right time, the outcomes of all our patients are going to be better. And I'm telling you that you have to be humble. You know what humble means? It means that you have to accept that you might not have all the knowledge and all the answers. So what I'm telling you, when I go through all the things that we're going to talk today, if you see another doctor and he's not telling you about these things, do not think that he's withholding information. Do not think that he's just not being truthful. It's just that the information is growing. And if you are in the forefront, it's very hard to look back or to look to the side. So what I'm trying to say is, if you talk to an oncologist, you talk to a radiation oncologist, you talk to a surgeon, they're all going to tell you different ways of how to treat cancer. What I'm trying to tell you is that in the near future, all those doctors are going to get together and talk and make a decision based on what's best for you. Personalized for each patient. You understand what I'm trying to say? The doctors are going to do their best. But as we speak right now, this knowledge is not universal. And you'll get there. And the way to do this is to share. The way to do this is to really look into the evidence. As soon as that's ready, I want to tell you that this problem with prostate cancer.
I think I got it. If you just tell me to go forward,
Go forward one slide. Perfect.
Okay. There we go.
One more.
Okay.
So we have a problem, right? 3 million Americans have prostate cancer. They are living right now, as we speak, with prostate cancer. The main problem that we have is that the outcomes of those patients will change depending on at what time they were diagnosed. And not only that, also what therapies are available for them. You understand? Once you have metastasis. And I don't know if you see it well here, but once you have distant metastasis, this prostate cancer is a completely different disease. You understand? It's a disease that is survival numbers are as bad as the worst cancers that we have. It's a pretty good disease if you catch it early. If it's late, there are significant problems. If we go to the next slide, I'm going to tell you that this has not changed. I mean, this slide was done in 2010. Basically, there's very little change to that graph. Maybe some different drugs here and there, but the idea is if you were fortunate enough to be able to be diagnosed early, local therapy would have been the best. And people that were treated early, they had done the best. If you pass through time and then if you see that the cancer is coming back, chemotherapy has put this in, and then at the end, you have lots of side effects, lots of interventions, but very poor outcomes. So we are really in need of something a little bit better. New therapies are really needed. So if you can go one more slide, I'm going to show you that this is a problem that we've been having for the ages, right? How do you differentiate normal cells from cancer cells? And I'm going to give you a little bit of explanation why I think that's important. Because if you finish seeing a patient and you only have access to specific data, you might, unwillingly, you might actually delay or prevent this patient from getting the right therapy at the right time. You understand? So we go to the next slide, and I'm going to show you that we're getting close to the future. The future is right now. And I'm going to show you some information that is going to be, I believe that it will change the way that you see this disease. The next slide is going to tell you that what you see in structures, structural anatomy, we mean CT scans, MRIs, bone scans, are a little bit different than when you look at the molecule with these unique scans that are becoming more and more, are becoming part of this care. Every day, more people are doing them. So in this case, you are able to observe cells, processes in a picture of yourself. So we're looking at the physiology, taking pictures. We're looking at the physiology. This cell is definitely different than this cell because it's behaving differently. It's expressing something that is completely different than the cells that are nearby. And in the next slide, I'm going to tell you this is the goal of caring for patients today. You need to find the right therapy for the right patient at the right time. Doing anything else is not acceptable because unfortunately now we have the tools. If we don't use it, it's just not right. So the next slide, I'm going to tell you that we are achieving this by actually imaging small flags or biomarkers of each cell. Then that is telling us what kind of disease do we have, what do we need to work with. And I'm going to tell you really fast because time is going. There is a molecule that its name is not as good. In the next slide, its name is PSMA. All right? I don't know, have anybody heard of PSMA here? Okay? So by the end of the talk, you'll know more. So this is a biomarker. It's a little flag. Just a little flag, you know, that is telling us that this cell, this group of cells, or this area of cells are expressing something that they shouldn't express. The actual name of PSMA is not too good because it's not prostate specific, but it is actually, the name was chosen because it's probably close to PSA. Anybody know PSA? for PSA is? Okay, there you go. So basically, the actual name of this is glutamate carboxypeptidase 2. It's a marker that is expressed up to 1,000 times more in cancer cells than normal cells. So it's a big difference. You take a picture and you know. In the next slide, I'm going to tell you, based on that discovery, we're able to define what patients are going to benefit from this therapy before you do the therapy. So there's no chance, I'm not going to say, well, sorry, we can't help you. No, no. If you are positive for this test, which maybe 90% of patients are positive for PSMA, that means that this therapy is going to help. If you don't express PSMA, it's actually good too. I give you good news, you know. That means that if your cancer is not as aggressive, so that means that all the therapies are going to work too. So this is they say that the proof of the pudding is on the eating, right? So in the next slide, you're going to see that this low PSMA, right here, low PSMA, you have low expression of this biomarker, you have a low-grade cancer. You have high expression of that biomarker, you have high-grade cancer. And in the next slide, I'm going even beyond and showing you that low expression of this molecule means that, right here, the survival of these patients are way higher. If you have high expression of this molecule, that means that your cancer is serious, right? That means that you need an intervention. In the next slide, I'm telling you that we are able to find the bad cancers, and we're able now, we have the chance now of targeting them instead of hurting the normal ones. And I don't know in the next slide, I think it's going to be tough to show you, but I can show you here. The next slide you have a patient that goes to the doctor and gets this imaging done. And the doctor says, well, the imaging is negative. I don't know if you have cancer or not, but the imaging, your imaging is negative. I mean that you don't have anything that I can see there. But what I'm trying to tell you is that you need the right technology to make that decision. And if you have the right equipment, you can see in the dark, right? And the wolf is there, but you couldn't see it before, but now you can see it. And I can show you here. It's all dark. But with this test, I mean with the right technique, you can see that this patient had a lot of disease. So, I mean, something like this happening is basically making me lose faith in some of the exams that we're doing. That's why I'm so excited to finally look at something that is going to allow me to help the patients. And not only me, it's going to help the urologist, it's going to help the oncologist, it's going to help the radiation oncologist, because it's helping the patient. Not everybody's the same, not everybody's at the same level. We need to make sure that we understand that there is a specific therapy that is designed just for you, right? So, moving to the next slide, I can tell you that this imaging is important, very important to detect this disease pre-surgery, in recurrence after you have had any kind of therapy, and even to guide focal therapies. And I'm going to give you a couple of examples. The next slide, I'm going to show you this patient that went to the doctor, and in a routine PSA exam, how many have routine PSA tests? So this patient had a PSA of 50. So I said, oh, man, this is something bad. I mean, I must have something. He gets this test, and this test is not widely available in the States, but in Europe it's very common. The test came up negative. This patient had prostatitis, he didn't have prostate cancer. In any other situation, he would have had to wait months thinking that he had prostate cancer. Now, we understand, if there is no dots anywhere, I mean, this patient have something that is not cancer, which is great. The next patient is a patient that went to the doctor, PSA was high, they had high suspicion for cancer, they did a biopsy, and the biopsy was negative. So, what do you do in that case? When biopsy is negative. You understand how biopsies are done in America? So, they put a needle 12 times and come out and check. One of those 12 times must have hit the cancer, right? So sometimes it doesn't work that way, right? I mean, in this patient, those 12 needle biopsies didn't show negative, no disease. We did this imaging, and then we biopsied that gut, and it was prostate cancer. Then he was treated very early, before he needed more things. So in the next slide, I'm telling you that it's important because it detects the disease at a very, very, very early point. From 0.2 to 0.5, when the PSA is 0.2 to 0.5, this is important in recurrences. After you have therapy, knowing if cancer is coming back is very important. If you have more than 2, then almost 100% of people show that disease, right? So what I'm telling you is, in the next slide, that the main point of this technique is to detect the cancer at a very early time. So the outcomes are changed. If I detect the cancer here, you already see this disease going everywhere, right? If you detect the cancer really when it's a dot, you have a lot of choices. And in the next slide, I can show you that knowing where are you standing, and in this case, this patient came in with, after a prostatectomy, rising PSA. He has had prostatectomy, and he has had radiation to the pelvis. So when the PSA started going up, he had access to this imaging, and you understand that the pelvis is pretty clean, but he already had metastasis in the chest. So this patient probably would have benefited from other therapy, not what he had. You guys understand that? Because if I take the prostate and kill disease in the pelvis, but you have disease somewhere else, you're getting this treatment, but it needs more. You understand? It needs more. So in the next case, there's a patient, and exactly the same situation. Well, a little bit, had a prostatectomy, PSA was really low, and they were saying, hey, let's, I mean, the actual surgery worked, right? The PSA was low. After a while, when they started, they were checking him, they decided, they were making a decision, should we do radiation therapy or not? This patient had access to this imaging, and if you can see here, there are metastases outside the pelvis. So other interventions should be used. Okay? The interesting thing is, in the next slide is showing you that you're able to detect metastasis in the soft tissues and in the bones. This is unheard of any imaging component. I mean, if you do CT, you can see some. If you do bone scans, you do MRI, but seeing the bones and seeing the soft tissues with high accuracy is unheard of. Let's go to the next. This is showing, bones and soft tissue. Next slide. I don't want to bore you with clinical studies and with numbers, but there was this multi-center prospective trial with 635 patients published in JAMA, showing that this imaging component has a very high accuracy, high reproducibility, means that anybody that sees this will come up to the same conclusions basically, and it has a big inter-reader reproducibility. That means that a doctor in Europe and a doctor in the States will see the scan and will come up with the same read. So in the next slide, probably the most important word here is high impact on management. If I see that you have a dot in the chest, I need to figure out what I'm going to do with you, because I know that working in the pelvis is not going to cure you. It's not going to help you the best, right? And in the next slide, I'm going to tell you that this is actually helping us making decisions, smart decisions, unbiased decisions earlier. So, how does it work? Let me show you the next slide. This patient had this test, and I'm not going to tell you the whole history. He underwent this imaging test, and we found a dot, okay? One single dot. So, if you go back one slide, I can tell you that you can find out what can you do with that dot. You can take it out with surgery, you can do radiation. One dot is very easy to treat. Before, we would have been thinking, what is the disease? Now, you can say, if you have one dot, we can do this thing. If you have many dots, we can do this other thing. So, it's basically bringing doctors together. And when we all say, right, when 2 or 3 brains get together, they think better than one, right? So in the next slide, I'm going to tell you, the next after that,
Okay.
that this is not the whole story. It gets better. So the next slide, I made that one more. The other way. The other way. One more. There you go. The funny thing is, why I said it gets better is because now that imaging test, I could use it to treat. You understand? So I know where the dots are, and then I can send my therapy to those dots, and the side effects are minimal. That's the best of all worlds, right? And next slide. So I think I was joking, I took that picture saying there's a match made in heaven. The next slide, I don't know if you can see it, but I'm going to try to explain. I have a nice picture, a nice movie, but it will work. You use this biomarker to take a picture. I showed you many pictures, right? Those black dots are areas where there are disease. So now that I know what the disease is, I can switch this camera, this little light bulb, right? Instead of doing a camera, I can do a little nuclear bomb, micro-nuclear bomb that goes just within micrometers of the other cells. So the normal cells don't get affected, the damage to normal cells is minimal. So the collateral damage is really low. This looks like from the future, right? But I'm telling you, the future is now. There are people getting benefit from this right now. In the next slide, I think, this one here is showing the whole video. The next slide, just think about it, just changing a light bulb, okay? And instead of burning the whole forest to kill the bad trees, like conventional therapy, with these targeted therapies, you are able to destroy the right tree and leave the other trees and the houses untouched. And I'm going to tell you a couple things. And the next slide, there is a patient with all those metastases. And I'm going to show you the whole study together from my friend Kulkarni. 119 patients. And out of all these patients that are actually patients with going to that clinic, after everything has failed, you understand the years that these patients have been on therapy. After everything has failed, with all the therapies available, and you understand that some of these therapies have a lot of side effects. You understand that when the disease is growing and with medication side effects, these patients are not doing as well. Still, in the next slide I can show you that these patients, a big percentage of them, like 76%, responded to the therapy. And the PSA, which is what the urologists like, and the oncologists follow, the PSA was decreasing in the majority of the patients. And the next slide is showing you what happened. You see this patient here? All these dots are metastatic disease. Here is the actual therapy. The therapy is going exactly to the areas that have the disease. And this is after 2 sets of therapy. This patient has a very good response. You see these dots are way less. Kidneys are normal, salivary glands are, they clean this medication. I can tell you more about that, but basically, in the next slide, I'm going to tell you the summary of that study, of those patients. 5 patients had complete remission. Complete remission means that they had no disease on follow-up, no disease remaining. Majority of them had some kind of control. But the important thing is you go to the next slide, it's going to tell you very important information. No evidence of renal toxicity, no grade 3 or grade 4 damage to the blood cells. Basically, very minimal side effects. If I show you the side effects of the chemotherapy used for prostate cancer, docetaxel, carboplatin, all these chemotherapy, the side effects are really long. I can tell you another slide in the summary of that study is that very promising results. More studies are needed. This is not FDA approved in the US, but under some clinical trial this is happening. And I'll be glad to talk to you about it in that. I mean, I can tell you, I'm as excited as you are, you know. I'm glad to be part of this. Right now, even we're trying to set this up at Loma Linda, and still some process, but there are some connections that we can talk in the future. But in the next slide, I want to show you with pictures. This is, if you cannot see it, this is before the therapy and after the therapy. Basically, very little changes, and actually the patient reported increase in quality of life. Patients were coming into this clinic in wheelchairs after the therapies, second therapy, third therapy. They were driving their cars to the clinic, which is unheard of. I was there in December, and the patient was telling me, "Are you sure you gave me medication? This looks like water, because I don't feel anything." Being in a oncology ward where patients are talking and eating and working, I'm like, something is wrong. I'm not used to see these things. But you know, with technology and with the right information, things happen. I'm going to show you a couple more pictures. I know it's late, but patient had a PSA of 0.05. Is that low or high? Really low. The oncologist said, there's no way this patient had prostate cancer. There's no way. With the PSMA test, and they did a biopsy, and for sure, it's prostate cancer. 50 or 60 cases of patients like that actually had undetectable PSA and disease that actually responded pretty good to the therapy. I'm telling you, there is more coming, and I think, let's go to the next slide. There is a big difference between the normal therapy available today and the therapies, these targeted therapies. And I want to show you the next slide. This is my favorite picture. This is our friend in Heidelberg. This patient came into the clinic with a PSA of 3,000, almost 3,000, 2,923. And after 4 cycles of the therapy, PSA is 0.1. And it's not only the picture that looks good, the patient looks good. Even patients in the next slide that are resistant to some of these molecules, when they change the radioactive medication, the disease progression changes. Now, the next slide is going to show you something that you might not know. These results that I were telling you before, this study that I will show you before, were in patients that had been heavily treated by other non-targeted therapies. Now, this therapy was performed in South Africa from this colleague named Mike. So Mike Satigi decided to do this targeted therapy in patients that couldn't afford any other medication. They just couldn't afford it, and he had this trial, so he treated patients before they got treated with anything else. And if you see here, out of 17 patients, 14 out of 17 had declining PSA after the therapy. 7 patients had undetectable disease after the therapy. 11 out of 17 had complete resolution of all lesions. So, of course, there is more studies and protocols needed. The next slide is showing you another example of how this is happening. The next slide, I can tell you that his conclusion for the paper was remission could be achieved. That's all. Those are big words. We don't say these words in oncology. I'm getting to the end. I need to tell you that probably the last 2 slides are not going to work because there's has some graphics and I'm going to put it in PDF. But we're working into getting algorithms that can tell me as a doctor how your disease is different, not only between different patients, but between your own metastases, because we know that they are different. If you run the right test, you know that the primary tumor is very different from the first metastasis, and the metastasis from here is very different than the metastasis here. So we're trying to understand how that works so we can actually treat the patient with the right approach. And go to the next slide. And this is the way we're doing it. Basically, it's helping the doctors read the scans a lot faster and way more accurate. So we don't have to sit there for an hour counting all the metastases. This interaction is helping us figure out what should we do for this patient now that we have all that information. Focusing on the patient and less on the information. So, in conclusion, I believe that, in the next slide, I believe that this therapy and imaging is very promising, and more trials are needed. But the trial that we just did, and I'm going to show you a picture. Another picture that in the next slide. This was in the LA Times. LA Times? Let me see. Yeah, the LA Times. Getty Pictures. Showing that even if the presidential candidates are saying we're going to cure cancer, I think they've been reading some of the stuff that we're doing. So it doesn't matter who you choose, cancer is going to do better. And the last picture, these are the trials going on right now. This trial actually stopped enrolling people because after seeing what the therapy does, nobody wanted to enroll in the non-therapy. So I think the information now comes to you so that we can have all access to something that is going to impact the way that your disease is treated. If you come to the doctor and we find disease only in your prostate, you have choices. And then, of course, prostatectomy, radiation, cryotherapy, high-frequency ultrasound. You can do whatever you want. It might work. If you have disease in your prostate and nearby, there's something that you can do. If you have disease outside the prostate, going all the way to the chest, then doing a prostatectomy or doing radiation to the prostate is not going to help you. It's not going to be the best help for you. Actually, I have a friend in the East Coast that did surgery. He's a urologist. He did surgery on the chairman of his hospital, right? Because, you know, the chairman of the hospital gets prostate cancer, he gets first spot in the OR, right? After 2 weeks of the surgery, the PSA kept going up. And he said, man, if I had seen this, if I had access to these pictures, I would not have had that. I gave him all the side effects and not benefit. So, you know, every time we do something in medicine, we say risk, benefits, right? Is this something that makes sense to us? This is helping doctors make better decisions. This is not about me being right. I was telling my chairman of urology, hey, if I don't get to treat one single patient, because you treat them all early, and they're all doing great, I will be the happiest person in the world. So there shouldn't be competition. Hey, my therapy is better. No, I mean, what therapy is better for you as a patient? You understand? This should be the goal, and this should be the way that we treat patients. What is the best therapy for this patient with his unique metabolic, DNA, function, everything? So, and I think that's the way medicine is moving. So you guys have the blessing of being in this age, day and age, where we have access to these toys that are revolutionizing the way that this is treated. And I'm going to finish with one last slide. I'm very excited about this too. Now we just found a new biomarker that is not specific for prostate. It actually detects 30 kind of cancer, 28 kind of cancer, basically every cancer. So now we can detect those cancers, and probably we can treat them in a safe way. And you know, if you think you have a purpose in life, and you see these things happening every day, and you see doors opening, do you imagine how many people we can help? I mean, I just think it's a privilege to be alive at this time, you know, and being a doctor that is working on this is just incredible opportunity, and I'm very glad to be part of this team that is trying to bring therapies for cancer that are not based on chance. the knowledge has to go to all our physicians first. This is pretty new. If you ask several doctors, they might not know about this, but the time is coming where everybody should know. And I believe that if you had had surgery in the past and they're monitoring your disease, you could benefit from the imaging. If you had had radiation, proto-radiation, or any kind of radiation to the prostate, you can benefit from this because then we know what is the stage of your disease today. Instead of finding out through the years and when the treatment is going to be harder. So that's why when I talk to my colleagues and the different specialties, I say, hey, do not see me like I'm trying to tell you that what you do is wrong. What I'm trying to tell you is that this can help you do something better for your patients, you know? Once everybody understands that this technology is here to help, it's not here to take business from them or anything like that, everybody's going to have access to it. And I think we're going to have to focus on other things because I can't wait until the day that we announce that there's no more prostate cancer. Right? We can start there. And I believe if we can detect it early and we can intervene early, we're going to move into that direction. Thank you so much for being so attentive here. I'm glad that I was able to be here and talk and share, and I'll be glad to answer questions and give you information. Thank you.
So, how much longer do you think we'll have to wait until we get FDA approval? And then the second part of my question is, how much does a scan cost today?
Very, very sharp questions, honestly. Those are very sharp questions. Actually, FDA is going to approve this when they see the need to do it, right? The evidence is mounting up. I can tell you that in Europe, where I'm working in collaboration with the group that did the first therapy, that have been doing this for the last 15 years, it's unheard of having a patient with prostate cancer that they don't do this image shot. There are clinical trials protocols in the US now doing this test under a clinical trial, and I think the cost is like $2,700 or something for the pictures. If you can talk to me, I have people doing it in other places in the world for a lot cheaper, you know. My friends in Australia are doing this for $500, $600, $700. So you can have we can talk more. I mean, the point is, this is coming, right? This is coming, and the more we talk about it, the more we ask, the sooner it's going to get here. I believe that in the next year, 2 years, the FDA is going to have to say, wait a second. They have all these people asking me for that. This is going to increase the cost of healthcare because I'm going to stop doing surgeries and radiation therapy that are not going to help. I'm going to start treating the right patient at the right time. So I don't know. I don't know exactly when, but I cannot believe that it will be too long.
I understand that your imaging finds a cancer.
Mm-hmm.
What I didn't understand is what the therapy is that takes the cancer away.
Good question. So we have a molecule. This molecule,
Do you want to go to the chart?
if you show me the pictures with, okay, keep going. Okay,
Back, forward.
go one more. Let me see. Keep going, keep going. Keep going. Keep going. More. When it comes to like, they have those three things in the little, okay, right, you're getting close. One more. So this key is PSMA. This is the molecule, right? Go to the next slide. The light bulb is a molecule. Same I mean the socket is the actual molecule, and the light bulb is what you attach in that keychain. So the molecule detects the cancer. You can take a picture of it, and once you have a picture, you can decide what you're gonna do. If you switch the light bulb, instead of a camera, you put a micronuclear bomb, then you have therapy. But the molecule is still the same. You're just detecting the biomarker that is associated with the cancer. So see it as a flag, right? I have a flag, and I have something that binds that flag. Whatever binds the flag, it does nothing, it just binds the flag. What you link to that molecule that binds the flag is what tells you picture, diagnostic, therapy. You put the micronuclear bomb, down the therapy. The molecule is, just think about the key, right? You have a key for your car, right? So it's unique for your car. So now that you identify the car, you can take a picture, or you have a little camera linked to that keychain, and now take a picture of the car, or you can put a little grenade and destroy the car. You understand? It's basically detecting the cancer. You detect the cancer. Once you detect the cancer, then you make a decision.
Okay, but is that nuclear bomb radiation?
It is radiation.
It is radiation. Thank
It is radiation, but not radiation in the conventional way.
All right.
It goes to that cell, and maybe, since it's a tumor, maybe they're close together, maybe 2 or 3 cells around that. You know, it's really it's targeted. If I give you, let's say, proton radiation, it has to go to normal tissue and then hit the tumor. And it's true that proton is really good. I mean, because you can give more energy here than at the beginning, right? But in this case, there's an injection that goes to the cells, to the blood vessels, and go to each little dot, and it delivers a picture or a therapy. And you can control that. Very good questions, you know?
It is my understanding that the lutetium PSMA 177, which was extensively tested in Germany,
Yes.
showed very promising results. But when it went into various clinical trials in the United States, all those trials had to be stopped because it did not show promising results. Can you comment on that?
Well, the trial that is the first phase 3 trial is called the Vision trial. The results are not reported yet, but on the experience that I've been exposed to with the highest volume clinic in the world, I will be I see patients there that have a 2-month sentence of death and return 2 years later. I believe that the data should speak. And I think once we have a trial like this, that it's open for everybody to see, and it's blinded by everybody, and you see exactly the numbers. The difference between Germany and here, this trial that is going on, the Vision trial, in Germany, you come in and they do it in a compassion base. So that means the patient come in, they see that you have positive marker for the disease, you get treated. There is very little randomization, you understand? So they cannot say, this study will randomize the patient from no therapy to therapy, and they did better than they didn't do better. So the trials that you were talking about, there might be small trials in different institutions, and they might be different ways of designing the actual medications. The importance of this trial is that they're using the same medication with the same dose, with the same parameters for everybody. I can tell you that we can talk more, and I can direct you to the team that is doing this in Germany. I don't see how this is not going to help.
So what you're saying is the trials that were going on in the United States, they were all using different forms of lutetium?
Not only form of lutetium, form of the molecule. So of the PSMA molecule. There is.
Why did they not just duplicate what Germany was doing?
That's a question for people with higher ranks. There's a lot, you understand that if I work with my molecule, now my molecule, I can patent my molecule, and it's my molecule, you understand?
Now we understand.
So there's a molecule that is called PSMA 11, which is the one that has been tested, that somebody decided to publish it and say, now it's free for everybody. You use it, but, So there are a lot of answers for different questions, but the bottom line is more clinical trials are needed, and this is the answer, this vision trial that is going on right now, where they are enrolling patients across the world, almost 1,000 patients.
If I may
Please.
clarify, the PSMA is a better detection method, a better scan, PET scan. It's not a curing method. It's a better detection method which allows IMRT radiation to do a better job than any other thing. It's simply allocating cancer cells or metastasis, whatever. But it's not a method, a curing method like, I don't know.
Okay, you're halfway right. When I'm using the camera to detect the PSMA, it's a detection method, and definitely it's going to help detecting the cancer and telling the urologist, the oncologist, radiation oncologist in what state of disease you are, so they make decisions, right?
Yes.
But now you can switch the camera. Let's say that you have metastatic disease with disease like some of the patients that I showed everywhere, right?
That's true.
So now the oncologist is your only answer, right? They say, we'll give you chemotherapy, because the urologist will not operate on you, you have metastasis in the chest. The radiation oncologists are not going to give you radiation if you have metastasis in the chest, because of safety reasons, right? So now you have a choice between chemotherapy and me switching the light bulb from taking a picture with PSMA to actually treating the patient with PSMA.
So there is a treatment associated with...
Yes.
Okay.
It's called theranostic therapy and diagnostic in one.
Okay. Thank you.
Hey, you're so welcome. Thank you for the attention.
Clarifies it.
Oh, excellent.
Are there any other centers where they're doing this clinical research? Or is it
There are
here in the U.S.?
There are several places in the U.S., and I'll be glad to send you the information. There are several places that
Kaiser does it.
they're doing this. Several places. UCLA is one of them.
UCLA.
Hopkins, yeah.
I think the PSMA scan is amazing, and the fact that you can target treatment with it is totally incredible. I have talked to my doctor about it, not that I'm a candidate at this point, but one of the side effects they mentioned, and in your slide, was dry mouth. However, he was talking about, in some cases, patients stopped producing saliva altogether, and it became somewhat catastrophic. Is that something you've seen?
I can tell you that if you are taking lutetium-177, which is a beta emitter, and you not have chemotherapy, less than 1% of patients have had any problems with the salivary glands. Now, several therapies after chemotherapy, all the things, even with lutetium, you might have some changes that are, in my experience, with that group in Germany that have treated thousands of patients. Lutetium is really low chances of damaging your salivary glands. Now, when we talk about actinium, which is an alpha emitter, it's like the difference between lutetium is I'm hitting you with a little hammer that is plastic, you know. I mean, I whack you with that and it's gonna hurt. But if I whack you with a solid hammer, the pain is gonna be more, right? So with actinium now, this has been seen, right? When you do a high dose actinium therapy, and I talked to probably 10 patients, 20 patients with that. I say, hey, the question is, am I gonna be alive to play with my grandkids or have dry mouth? I choose dry mouth any day. I'm telling you, this is not something that I take lightly, you know, because having dry mouth, that means that the way you eat changes and the taste, all these things. Now this group in Germany is doing low dose actinium combined with lutetium. So it's called tandem therapy. I mean, I don't want to confuse you, but for patients that are advanced and that you need to do something because this is it, right? After this is it. With those combined, low dose actinium and lutetium, the damage to salivary glands are minimal. So, of course, there are things that they're trying to do to figure out why salivary glands, you know. This is very different than prostate cancer. Why are we going, what is the treatment going there? So we're designing different molecules. In a trial, they injected Botox, you know, for the girls to be pretty, injected in the salivary glands. Now the salivary gland didn't take the therapy, so it's fine. So the things that are happening, but you have to understand that the risks and benefits. If I show you the risk of chemotherapy, I would spend the same amount of time talking about the risk. It's not a simple. This is not simple, guys. There are thousands of people trying to come up with different protocols, and I can tell you, as of today, if you go to 10 doctors, you might get 10 different treatment plans. I think in the future that has to change. This information needs to get to everybody. The reason why I'm collaborating with this group over there is because they have the most experience in the world. They have seen the more patients. They have failed many times, and they have learned from their failures. And these patients are doing better now. There's something to that. And just like when you go and have your cataract surgery, right? You go to the doctor that has done thousands, because that guy knows what he's doing. I'm not saying don't go to the one that has done one, but go to the one that is doing a little bit more. So, because when you get good, human beings, you know, when they experience doing things, they tend to get better. That's why we have subspecialties doing this, you know. Hey, my friend, how you doing?
Good. I have a friend who lives in the States here, and he's made, I would say, probably 2 or 3 trips to Australia. He is quite knowledgeable about his philosophy, physiology, and his, anyway, he went down there to have the theranostic medicine done, and he was not happy, and he, of course, everybody's individual, as you know.
Yeah.
And he feels that he got shortchanged in terms of what
Definitely.
his expectations were. And he came back, and he was wanting, he's very analytic, he was wanting to have a good scan done, after he had these things done, several trips going down there, to have a, not the theranostic intervention, but to have a scan with PSMA to see how things look, afterward. And he had a report of what he says was not a very good report from the same group in Australia. He went to UCLA not to have the theranostic done.
Just the
but
pictures.
Just the pictures.
They can only do
They
pictures now.
gave him like a telephone book full, of all the different things and everything. As far as the expression of reading the PSMA scan, he was very happy with the UCLA group that did that imaging scan afterward. So the question is, I guess maybe we don't want to hypothesize that the group in Australia may not be as up to date as the Germany or what,
So this all started with the German group, right? Germany changed the law and said, hey, we're going to allow doctors to do this under strict guidance. Australia learned from Germany. I know the people in Australia. I'm telling you, it's not the imaging is the imaging. It's the same here and there. It's just how do you interpret that imaging, and it's not the arrow. It's the Indian. So it's not, and there are many things. I mean, you need to have doctors that are passionate for this. I will send anybody to get pictures anywhere as long as I get the CD, the images, and I'm able to talk to that patient. Because you need to make sure that you are the one talking to the patient and say, hey, this is you here. This is what we are. The interaction between a doctor and a patient with all this technology is required. This thing where you have to take a picture and they send you a report, this is not the way it works. This is changing the way that things are done. From the pictures to the treatment, you have a doctor that is an expert in the imaging and in the therapy, and any other way is not the right way. Sorry.
Now, my question is, when should I take the PSMA PET scan? Is there an interval, like every 2 years, 3 years? I'm post-radiation, 4 years out. And my PSA is about 0.2, I think. It's
Pretty good.
It's not zero, but it's around 0.2.
Yeah.
But should I take this as a like an oil change? In other words, every 3 years or 4 years or 5 years, or should I take it now to see if my results are clinically stable and zero metastasis?
Metastasis, yeah, metastasis.
Yeah. I mean, should I be concerned, or should I take advantage of this test? I mean, I can afford it if it's $2,700, whether it's insured or not. I'll just write a check.
I can tell you that right now, whatever I can tell you is not proven, because we're just starting to do this. I'm actually creating a trial just for patients like you, because, hey, you need to know, and it's better to have a baseline and then look back 10 years from now, oh, this changed, so there might be something, or maybe a differentiated cancer that is not showing up like some of these things. Usually, I can tell you that those little dots, those little questions following the dots are going to be changing while we get more information. And I believe that in your case, you're doing great. I mean, as long as you keep this in mind, if something changes, I mean, the standard of care for you had worked, right? I mean, there are other people that the PSA is 3 or 4 after the radiation. So you have to understand that we're still trying to figure this out. We have the gun now. We need to make sure how we use it and how do we use it in the most effective way so we can do the most help. But I'd be glad to give you my information, and whenever you have it, we can talk about this. And the radiation is really low. For the pictures, it's like going from here to Europe in a plane. So I probably get 10 of those because I've been traveling back and forth.
Does it require an MRI or does it require 3D?
It's a PET CT. A PET CT. It's a CT scan with this special.
Or you can use that with a pacemaker?
Oh yes, no question, no problem with that. You don't need an MRI. And I know it's late, but you can talk to me afterwards. I have my cards. I mean, this is something that you're gonna have time to think, and we can work together for a long time.
As I told you when you first came,
Yes, I remember.
I got the proton treatment of Melinda where you were. And now this is the first time I hear about this PSMA. Is it available? Do you do this on Melinda?
We are gonna have it in the Molina soon, but right now I am seeing the patients and I'm scheduling the scans with different collaborators. But this is gonna help the proton therapy group because we're gonna know which patients are gonna be helped or not. Like I saw a patient last week who spent cash money to get radiation therapy. And a lot of money. And when they did this test, he had mets everywhere. He probably delayed the right therapy for 8 months because he was doing this without having the actual knowledge. So, just keep in mind that there are things that are going to be helping the way that your disease is treated. And this is only going to become more and more available. Like, there are people charging $50,000 just to get you to the right track so you can get this imaging and this therapy. I believe that's a little too much, you know. But that's why this is going to change, right? More of this information is going to get to the people without costing you.
Okay, so I think we have time for one more question, if anybody has a question. Does anybody have a question? Okay, Doctor, thank you very much.
It has been shown that